I'm Derek. I'm a paediatric emergency medicine registrar at Nottingham Major Trauma Centre. And a long time ago, I was a paramedic. So I was a paramedic in Manchester, and then an emergency care practitioner. And then I'm joined with Dawn and another person of KidConfident. So I'll let Dawn introduce herself.
Hi, good evening, everyone. So my name's Dawn. I am an assistant professor of paramedic science down at Bradford University. I'm also an enhanced care paramedic with the North East Ambulance Service, and I am ex-military, so my trauma kind of background comes from there mostly. But again, as James said, we work for KidConfident and help making this accessible to you guys. So I hope you enjoy this evening.
Cool, thanks, Dawn. So Dawn's going to take the second part of this presentation, but she may well chip in as we go along as well. So without further ado, let's start. So what we're going to talk about, why on earth do paediatricians go on about how special kids are and how different we need to approach them and stuff. And so what's all that fuss about? So we're going to address that. And normally that involves James saying how terrible paediatricians are. Well, I'm a paediatrician, so today I'm going to be apologising. So we'll go through that. And then the main thing that we're going to look at, maybe from my point of view, is going through an approach to a paediatric trauma patient and doing our CABCDE approach. We're going to look at managing pain specifically in children, and then Dawn's going to take us through coping with a scene with distressed parents, managing scenes generally with kids, thinking about safeguarding and what we do about that, transfer issues, and then handover. And then obviously we're going to have some time for some questions afterwards. So let's crack on. So if this is paediatrics, a special, I've spent 8 years training all about kids, so there must be something particularly special that you need to learn in that. But the truth is, there isn't that much. And actually, paediatricians like to tell us that you're going to have to deal with something you've never dealt with before. There's going to be this monster that's going to be completely different from everything that you ever know, and you should be afraid of sick children. And at KidConfident, we want you to take away, and the whole point of this is to say, actually, I'm a paediatrician, and I apologise for all of my colleagues. Generally, people think that kids are different, but remember that paediatricians don't really look after adults, so they don't really know, and they can't see the parallels between the adult world and paediatrics. But from our point of view, in trauma, a child is like a small adult. Okay, so I want you to think about just a normal person and treat them exactly this way as you would normally if they were a little bit bigger, and certainly if they look like an adult, treat them like an adult. If they look like a child, treat them like an adult, but just scale down a bit. And we'll go through some little changes, things you can think about, but generally don't let fear stop you doing stuff. So this is my mission, to tell paediatricians to change their view on this. I don't know if there are any paediatricians on the call, please have an argument with me. And we've even got T-shirts that say, and I noticed that Anna was wearing one on the call, so well done. But actually, what we want to do is improve outcome for kids, and actually we want to get over the fear of things are different and crack on and do that. So let's do that. So what I want to do is put a placeholder in this conversation, if that's okay. What we're going to think about is and after my little bit, we're going to think about what we could do on the way to a paediatric trauma call. And I'm going to give you a scenario to think about, and then we can think about what we might want to put in there and have a think about that. So you've got a call to an 8-year-old who's fallen 20 foot out of a tree, and off you go in your ambulance. What can you do en route to help you? So catastrophic bleed. All right. So if the way you treat catastrophic bleed, unsurprisingly, is the same in adults as it is in the same in kids as it is in adults. One thing I would say though is if you think about blood volume and what you see of blood on scene on a trauma scene, sometimes there's a lot of blood and you think, okay, that's a lot of blood, or that's not much blood. Okay, but if we think about circulating volume for kids, it's about 75 mils per kilo, and it's about 70 mils per kilo for an adult, but they're a bit heavier. So if you've got a 2-year-old, 10 kilos, 75 mils of blood is 10% of their circulating volume. So if you're seeing blood, then take note of that. But if you've got catastrophic bleed, you're going to do what you normally do. You're going to use dressings. Hemostatic dressings are going to pack wounds. You're going to use tourniquets. People worry about tourniquets on kids, but if they've got catastrophic bleeding, whack one on. If that's not working, whack another one on. Same as with adults. And this isn't just something that KidConfident is saying. This is something that the American College of Surgeons have supported KidConfident with Stop the Bleed that James has done, which is on the KidConfident website, which you can go to if you want to for further learning. So airways. Another thing that paediatricians, and I would say, James, anaesthetists, paediatric anaesthetists, which James is, always go on about how they're different. And they were pediatric anaesthetists always telling me how different pediatric airways are. But actually, in the scheme of things, that's only if you're going to intubate them. They've got these changes in their upper airway maybe, but actually all that you want to do is put air in the lungs and let air come out of the lungs, and there's nothing that an iGel won't overcome. So it doesn't matter, ignore it. But what I do want you to think about is actually positioning of airways, and that is there's some slight differences in that. So let's talk about that. You may have come across this slide or these pictures before, where kids have got big heads, and the smaller they are, the bigger their head is in comparison to their body. So when they're a little bit floppy, when they're sick or unconscious, their chin will go on their chest and they will obstruct their airway. They will obstruct their airway without a doubt. And so we want to think about that and trying to open their airway. For under ones and sort of that sort of age group, we're looking at a neutral position, which again I'm sure you already know, but sort of this second picture with a nice tick on it. So just trying to bring the head in line with the floor that they're on. Older kids, you can do a head to chin lift, but that's actually, it's just not as much as you would do on an adult. But if we're talking trauma, then jaw thrusts are our friends, aren't they? Same in adults. All I would say is on little babies, jaw thrusts can be slightly tricky if you've got to make sure your fingers are on the hard bit of the jaw. If you're pushing into the soft part of the jaw, then they can obstruct their airway really easily. And sometimes in the panic of things, then your hands can slip. They've got little heads, so just try and make sure your fingers are on the bony parts rather than the soft bits. And then I want you to just sort of see what works. So what we're looking for is chest rise, isn't it? Fogging of the mask, ET and tidal CO2 if you've got the monitoring. And if it's not working, change something. Move the head back a little bit, do a little bit more jaw thrust, and see whether or not what works, and whatever works, great, carry on doing it. And the same as in adults, isn't it? If things aren't quite working what you normally do, you can reposition and see how you go and carry on as you are. So we can, sometimes you need more hands, and all airways are really useful. I know when I was a paramedic, although it was a long time ago, the little OP airways never came out of the bag, never came in the packaging really, and they were just there. And God knows what the sell-by date with this, because this was a time before we had like tabs on people checking all the dates of things. But they're really useful. What I would say is just make sure that they're well sized. So normally you can just look at an adult and say what size they are, but in kids you don't do it as often. So check from the middle of incisors to the angle of the jaw, and we don't invert, insert, rotate. We pass it in this plane that you want it is, and you're passing it over the tongue. the teaching is to use a tongue depressor or something like that, but actually just open the mouth and try not to scrape the top of the hard palate when you're popping it in. And then, if it's too long, it'll stick out, and that could cause trauma to the back of the throat. And if it's too short, it's not going to pull the tongue forward. So you should know whether or not it's going to work or not. And if it's the wrong size, don't panic, put another one in. And we've always got eye gels. Oops, sorry. So chests and breathe. B for breathing. So kids love oxygen. Always give oxygen. It's something easy, and they desaturate quite quickly. So oxygen is always a good idea. If they've got tension pneumothorax, decompress it. And that's not rocket science, but sometimes scary. And then analgesia is super important. We're going to cover that a bit more in D. But if it hurts to take a deep breath, you're not going to take a deep breath. You're not going to move much gas. So don't underestimate analgesia in chest injuries. So let's talk about decompressing pneumothoraces, which is something that sticking sharp things in children sometimes feels hard. But if they've got a tension pneumothorax, that's what you need to do. And if they haven't got a tension pneumothorax and you thought they could do, and they've got chest injury, then you're not going to do much harm by popping them on it, even if they don't have a tension pneumothorax. So we could obviously the cross on the picture, sort of what we're saying is midclavicular line, second intercostal space, going on the superior portion of the rib is where we would suggest. And sometimes people worry about what size cannula to use. It doesn't really matter. A cannula of some sort. Don't think just because they're small, it has to be a small cannula. But whatever's in your hand doesn't matter. There's some thinking sometimes that, I don't know if people are aware, but in small babies, everybody's got a thymus gland. It sits just behind the breastbone, our sternum. And in children, it's particularly bigger than in proportion. And so people worry about pranging the thymus gland, sometimes doing the anterior approach like this. And the alternative is to go in the fifth intercostal space auxiliary line. But when I tell you that the heart is probably about 50% of the rib cage in a baby, then you've got a risk of pranging the ventricle as well. So no two ways are wrong, and actually there's no particularly wrong way of doing it. But maybe nicking the thymus is less of a problem than nicking the ventricle. So if you can think about it, you can pop a water-filled syringe, so a saline-filled syringe, onto the back of take the cannula off the back of a cannula, stick the cannula on, and advance the needle with back pressure on the syringe. And as soon as you get bubbles, slide the cannula down into the chest and remove the needle. If we also talk about the 3 R's. So we've talked about repositioning the airway and previously. We can reposition the child. So if we can do, if they're not concerned, it's just a chest injury and you're not worried about spinal injuries, and you can sit them up and help them use their muscles to breathe. But if you're unable to do that, then try and put the injured side of the chest up to the good side of the chest up, so the injured side down, and then remove any restricted clothing. Oh, come on. I don't know what's going on with my presentation, sorry. So I went from B to D, that's certainly not right, is it? So C. So if we talk about cardiovascular instability in kids, people always love talking about, kids hold on and then decompensate and fall off a cliff. And that is true. They've got very good hearts. There's nothing wrong with their hearts, and they maintain their blood pressure really well up until their heart just can't do it anymore. And you see this sort of cliff edge of a blood pressure. And in adults, the decompensation line is much more sort of gradual, and you'll have more warning of hypertension. I would want you to try and get IV access and think about giving fluid boluses. And certainly if you've got low blood pressure, and if we think about blood pressure, I would say it's all different in different age groups, and please use aid memoirs if you've got them. We can talk about. We've got some that we can share on KidConfident, or there are others. But systolic blood pressure plus twice of the age is where sort of a normal a normally high blood pressure, which you could be aiming for. So, you know, if you've got a kid with a very high heart rate and they're cold from their up to their knees and cold up to their elbows, then a bit of fluid bolus is probably a reasonable thing to do. Permissive hypertension in trauma in kids is not a thing. It's something that isn't supported by anybody. So we need to try and maintain their blood pressure. So how are we going to, so access, by all means, stick a cannula in if you feel comfortable. I know that when I was a paramedic, I was scared of the idea of using tiny little cannulas or using bigger cannulas on small people. But if you're comfortable to do that, then do that. But I would say only use 2 attempts. And if you're unable to, then an IO isn't indicated. I would argue that if they've got an unconscious trauma patient, or we're in peri-arrest situation, or it is an arrest situation, don't bother with the cannulas and just pop an IO in. This is a lovely poster that's on the KidConfident website that was done by one of the critical care paramedics that works with James on the helimed. And, you know, it goes through how to use IO and the landmarks, you know, sort of distal femur and more sort of humeral head, and then after over 6, then in the proximal tibia. One thing I want to say about IOs is you can only get a little bit of blood in it. And moving on to D, though, I really want you to try and do a blood sugar off that. And then finally, sort of pelvic binders. Pelvic binders are super important. We put them on, even if they're small, and we should improvise. So our pelvic binders are a bit big. Sometimes you can cut them down and use them. And if you really can't get the pelvic binder to fit, then you can tie their knees together and tie their ankles together, and that will help close the pelvis. James tells me about orthopedic theatres where they'll have somebody just holding their legs together with their ankles together, while they take the pelvic binder off to do the pelvic surgery, just to keep the pelvis close. That's something we can do pre-hospitally. I don't need to worry too much about the falling off a cliff bit of the of kids, because actually, you know, they do very well, and they give you time generally. But if you have got blood pressure problems, then I want you to give them fluids. And as we're coming on to E, we're going to talk about temperature, and giving cold fluids to a cold kid is, you know, sometimes necessary. But if we can give warm fluids, even to a warm fluids to a warm kid, that's even better. And warm fluids to a cold kid is super, right? So 5 mils or 10 mils per kilo is completely reasonable. Probably 5 mils. You can always give more, so I'd probably go for 5 mils. There's always questions around this, so phone matters. So unfortunately, kids get head injuries quite a lot. They've got big heads with not much control on their neck, and it's probably under ones the most significant mortality and morbidity from head injuries. And they can have spinal injuries, but they tend to be high. So you know, it's a difficult thing knowing how to manage sometimes with a kid. Strapping small toddlers down onto boards doesn't normally go very well if they're conscious. So it's in the same way if you've got an aggressive alcohol fueled head injury, strapping them down sometimes to a board isn't the best thing. So just play by, if they're going to do more harm by being strapped down, you can't keep them happy and still, then you know, just let them move and manage, and as long as they've got normal neurology. And then sort of glucose. So I mentioned before, so glucose is something sometimes that's not covered that much in trauma teaching, but in kids it's super important. They really need glucose for their brain, and we often see glucose being a problem because kids aren't able to maintain their glucose very well when they're sick. The livers aren't great at creating free sugar. The glycogen stores aren't brilliant, so they run out in a stress state really quickly, and then the brain hasn't got anything to use, right? You can give them oxygen, but actually we're missing glucose, and that has a massive impact, particularly on head injuries, and there's good evidence to show good sugar control improves outcomes massively. So I want you to have a little bit of blood you got out of your IO, or if you can't get anything at all from just a blood sugar, think about correcting glucose. Again, warm if you can do it possibly. but you know, it's something that's easy to do, and it's something that's common in kids in trauma. So please think of it. The other things to think about. So in head injury, which James is going to talk about in June, he's going to do a webinar particularly on head injuries in kids. But you can have their head up a little bit. Temperature control and sugar control are super important, and there's other stuff as well that we can think about for head injury specifically, but I'm not going to cover at this point. And as a cliffhanger, please listen to James's talk. And man, what is going on with my buttons? So pain is also in D, isn't it? Right. So pain's super important. This is a pain approach that KidConfident and Bath University and the Paediatric Blast Injury Group put together, and I really like it. It's useful in adults as well, I would argue, but in paediatrics, and this is there's a pain book that's being produced as well, which we will look at in a minute, which is also on the KidConfident website. But basically, give analogies here, right? So kids are in pain, kids are scared, and you will get much better outcomes and compliance if you can manage pain properly. And if we think about sort of the core principles, this building is built on some foundations of core principles, which is about being having a safe environment, being honest, never lie to a kid, they will always find you out. Never say something isn't going to hurt when you know it is, for example. Involving friends, families and caregivers, and trying to make a sense of security. And then physical interventions, such as putting some cling film on a burn or putting a cold compress on something, that just gives you some instant relief, or immobilizing a fracture in a comfortable position. Pharmacological interventions, like everybody just rushes to and thinks, right, I've got to do that. That's what pain control is. That is really important. I want you to give paracetamol and ibuprofen if you can, and then opiates are super important. So Oromorph or IV morphine, don't be scared of you using them, because that's the first thing we'll be doing in ED. And actually, if the pain's better controlled, they'll probably breathe better. And you've always got a reversal agent, which I've never seen used in kids in this circumstance, I should add. And then psychological interventions. And that's sort of probably the thing I find is the biggest thing about being distraction, about having something on your phone they can play with, using parents to talk to them about something that they like doing. And you can do all sorts of things with kids. That sounds awful, doesn't it? You can do all sorts of things with good distraction. You don't have a play specialist, I appreciate that, but you are your own play specialist. So be imaginative, have fun, and try and use that. And the idea of this building is you can take out the middle bit, the pharmacological things, and build it. The building will still stand up. If you just have the pharmacological things, the roof is pretty wobbly. So think about that. And then there's this pain approach. So pain approach of preparing, assessing, intervening, and next steps. So we've got KidConfident again has got a card that you can use and to think about how you might prepare for managing pain in a child for their age and working out their expected weight off that. And then plan for physical interventions, what you could do, so burns or dressings, immobilization, psychological interventions, so distraction, all the things. Get you. I don't know if people do have apps on your phone that they can use for distraction, games and toys. Try and score the pain before and after intervention, which is super hard. And there's wrong faces, sort of unhappy faces to smiley faces. Again, that's on the KidConfident website, but you can find all places, and you can adapt. And then your dose, just trying to work out your normal doses of things. And that, I would argue, is something that we could do pre seeing the kid, to try and work out how we're going to do that, to give you some bandwidth when you're actually there. Why does it keep jumping? I'm sorry. I'm heavy on my fingers today. So E, everything else. Again, these are, you know, you may say this is all like I do for adults, and it is. Okay, so what I want to really drill home though is trying to keep them warm. Okay, so you've probably heard of the trauma triad of death. So acidosis, coagulopathy, and hypothermia. Kids get cold really quick. They've got a large surface area to lose their heat through. They've got a rubbish liver to keep them warm. So sick kids get cold quick, and you know, trauma tends to happen in cold environments. That's well, maybe you have a trauma in a baker's kitchen. I've never seen one, but actually, kids get cold quick, and you know, adults don't tolerate it well, and kids tolerate it even worse. So you know, you have poorly perfused limbs which are cold because blood's not getting to them. That creates more acidosis. The acidosis makes your clotting proteins not work very well, and you end up in a vicious cycle of getting colder, getting more coagulopathic, and more acidotic, which is never a good thing. So what I want you to think about is trying to keep them warm. Transwarmers are your friend. In my day, I used to have a warm cupboard in my ambulance for fluids. I'm told reliably that those don't really exist anymore, which is a shame. But what I would say is there are other ways to keep things warm. So transwarmers, your own body heat, stick your fluids up your jumper on the way, which will focus your mind, obviously, because it'll be cold. But it's an important thing. Do your sugar and make sure you're addressing that. And then packaging. So use foil blankets round a scoop to make a burrito. Make sure you try and get the ambulance as warm as possible before you're going there, and keep the doors closed, and then try and get it as hot as you can on the way in. And then obviously splinting fractures and making sure you've got the other things sorted. So as you can see, the next slide, see if it jumps to up to again this time. No, it hasn't. There you go. The next slide, as you saw before, was traumatic cardiac arrest. And we are going to talk about this because unfortunately it does happen. We do see it. It's not nice, but it's important to address it. So, you know, again, although scary and horrible, this is exactly the same as what you do in adults. So the hands-off and hot approach. So not going on to chest compressions and not giving adrenaline, but actually reversing the reversible causes of a traumatic cardiac arrest. And you know, so the reversible causes we know for traumatic cardiac arrest is hemorrhage, oxygenation, and tension pneumothorax, and tamponade. So when we turn up, it's really difficult to not just go into CPR mode, and particularly with a kid, you panic and you may want to just crack on and move. But these are life-saving interventions, and I want you to have a pattern or a medical model, a mental model in your head about how you'll address this. So James has this recipe which I really love, but tube down or eye gel down, right? Stick an eye gel down, long bones to length, pelvic binder on, decompress the chest, and then a thoracotomy. You may not have the skills for thoracotomy, but there may be help coming, or you may have help there that will be able to have those surgical skills. Thoracotomies are, all of these things are sort of extremists, but thoracotomies really only has evidence for penetrating trauma. And so I wouldn't, the important thing is for you to do things that you can, and then make a decision about moving or waiting for help. And then again, I'm nicking this from James, but Phil Godds, who's a air ambulance guy, says your patient in PARS is not dead. They're trying really hard to stay alive. And that in kids is super true, right? Their hearts are fresh, they're healthy, they will beat as hard as they can. And if there's, and they will keep doing that. So if you've got a kid in PAA arrest, work on them as hard as you can, give them everything that you can, because you may get a good outcome. So extra skill sets. Hopefully, if you're going to a paediatric trauma call, these are all people that will be already told are on their way. But if they're not, that's something that you could be doing on your way, to be making sure you know what resources have been mobilised to you and how long that's going to be, there, because that will help you make decisions around managing your CE. So we're going to come back to what to do en route. I would argue that the things that you need to be doing en route are trying to take a breath, right? Remembering that this is just a trauma call, and I will do exactly the same as what I will do in an adult trauma call. So you've got an 8-year-old that's fallen 20 foot out of a tree. They could have all sorts of injuries, and you would address them in the CABCDE approach, just as you would. Aid memoirs are super important and helpful in these cases, and give you a little bit of thinking space of when you're there. So if you can, try and use an aid memoir to try and look at normal observations, look at the drugs that you need, and if you are able to get the ambulance as hot as you can on the way, snap your trans warm and get that working, get that nice and warm, and you can get your fluids warm. And then know where you're going. So paediatric major trauma centres, you probably know where your local one is, but moving to the right place. KidConfident has the only map of all the UK paediatric trauma centres. So go to the website and have a look if you're not sure. So those are things you could do on the way if you've got time. I appreciate that sometimes you're trying to work out where the hell to go and what sort of information is coming to you, but things to think about. And then aid memoirs. So these are some aid memoirs. We know we've got JRCalc Plus app. On the KidConfident website, there are normal blood pressures, heart rates and rest rates charts, and then there's also Kids Cards, which is a partner thing that is available through KidConfident as well. But Kid Cards is produced by and gives you a really nice age specific what to do all in one card, which is something that you can get and stick in your pocket size, and is really super useful. And then also on the website there is the pain management for injured children, which goes in detail about how you can manage kids' pain pre-hospitally, which is super good, which James and the Paediatric Blast Injury Group did. And if you scan that QR code, it will take you directly there. And then the Paediatric Blast Injury Field Manual is also something that the KidConfident James has been involved with, that has a really good pre-hospital part in it, which talks about, so this is all designed to help people in war zones or places of conflict, but it's got some really super common sense stuff in it, and that takes you all the way through to rehabilitation, but the pre-hospital bit's really useful and it's worth a read. And these are all free on the KidConfident website. So I've done a lot of talking. I'm going to hand over to Dawn.
Okay, thank you, Derek. So I realised I was putting some bits in the chat, but you can't see them because it was actually I don't able to send it to everyone. But it was things that we were talking about, the drop in BP. So the things that you should be looking out for before we see that drop in blood pressure would be that increase in rest rate, that increase in heart rate, and the prolonged capillary refill. That means they're still trying to compensate at that moment in time. And it's when we start seeing those drop that we know that they're not really compensating very well. Looks like I froze there, but as long as you can still hear me. So Derek spoke to you about the technical side of this. So I'm going to speak to you about the non-technical side. So what we're looking at here, oh, I don't know if my system is going off here, apologies, but is thinking about those parents, bystanders, etc. So one thing that comes with children is generally a parent, and they'll be somewhere. Okay, so to keep them, oh, it's not working. So to keep them calm as best as possible, try explaining what you're doing. So imagine you're in an OSCE and you're telling your examiner what you're doing and explaining why you're doing it. That's essentially what you're doing here. Okay. So explaining will help to keep them calm. It'll also help those bystanders, because obviously bystanders as well generally get quite anxious and get quite loud as well and want to help and want to do things. Obviously, yeah, feel free. Please utilize those bystanders, give them a helpful job, whether that's stopping traffic, holding a bag of fluids, something along those lines. Keep them busy, make them feel useful. Okay. And then when we look into mum and dad, use that terminology, use mum, dad, to try and help them focus on their role within this situation. So with that, it'll help keep them calm and hopefully focus their attention on that child and help you with the care that's needed. So think about that psychological element of pain relief. It will help there as well. So it'll help calm the child and it'll also hopefully help calm the parents. But again, those parents could be angry at each other. They could be also feeling guilty, even if it's not their fault that the child has become injured. So a little reassurance will go a long way. Okay. And this in itself will also help calm yourself down and calm those around you. But don't let their questioning and their want to comfort their child get in the way of your care that you are giving. So yes, they can be there, they can be comforting that child without holding them so tightly that you are having to pry the child away from them. But they can be there, they can be at the head end talking to the child, they can be distracting them, and things like holding their hand whilst you're doing procedures, so on and so forth, and you're managing that child. Because there is certainly some good evidence out there that suggests that obviously if the parents are present during that treatment, especially in resuscitation, okay, it's also good for the child and for the parent. You know, they can see that everything is being done to help with that child. Okay, next. Thank you. At least I know I'm still on. I say I think I'm frozen, but there we go. Okay, so when might not you want the parents there? So thinking about this, okay. So obviously you're going into the scene, okay. And then this, we're thinking mostly kind of safeguarding here, and it's a topic by itself, and you will be doing all your usual safeguarding yearly updates and so on and so forth. But remember, who's your number one priority? That is the child. That is the injured child. And again, just be mindful that if they are interfering with the care, so they are holding the child, they keep getting in the way, so on and so forth, politely, okay, remove them from the situation. Can they be getting something ready? Okay, look, we're going to go to the hospital. Can you maybe get a few bits, any medication, so on and so forth, and kind of get them out of the way as much as you can. Okay, now thinking about NAI, so non-accidental injuries. So this is quite prevalent in the under ones, and around 50% of NAIs happen in the under 5 months.
So it looks like the frozen dawn has unfortunately frozen out already. I imagine, excuse me, I imagine she will be back on any second. It was probably just a few connectivity issues, and hopefully she's not just talking to a blank screen and is carrying on going without realizing. So we'll give it, I don't know, James, if you want to.
Yeah, shall I jump in? Shall I jump in?
Yeah, I was going to say, if you want to jump in, and then when Dawn arrives, she can pick the baton up.
Yeah, no problem. She'll tell me to shut up quickly enough because she's very good at it. So, yeah.
Brilliant.
Cheers, Anna. So, like, yeah. So as Dawn was saying, there's some times that you might not want the parents to be present when you're looking after the kids, and you all do your safeguarding mandatory training, and we spoke last time actually about this is something that you start assessing as soon as you arrive at the scene. So you're taking in all the information try and assess whether there is any untoward reasons for the child to be injured. And as Dawn was just saying before she got cut off, the time you're most likely to sustain major injuries, major trauma, as a child is under the age of 1, and under the age of 4 months is the really high peak. And unfortunately, the reason for that is the most common reason for that is suspected parental abuse and non-accidental injury. So if you do notice that there's a funny dynamic between the child and the parents, and they're not being consoled, or they're scared of the adults that are around, then you might want to remove them from the scene, because that might it will interfere with how you are going to be able to get them to cooperate with what you want to do and move forward. If you're not getting the full picture on the history in older children, because they seem suspicious of or worried about telling you what exactly has happened because of adults that are around, then that might be a time that you want to move them off the scene and get them outside. And that's the same as if they're interfering with care. Obviously, these are emotional times, and the parents are very worried, and they obviously majority of the time would want the best for their children, but sometimes their rational behavior goes out the window a little bit. And they just want to be hugging their child and consoling them, and they're kind of getting in your way, so you can't do what you need to do. So that's another time you want to get them to leave the room. And things you can do is just, calling them mum and dad to remind them of their role in the whole situation, and explaining that you need to care for their child, and you need to concentrate on that. And it might be possible if it might be easier if they waited in another area, or you can send them off to get stuff. And I like to come up with really random things that are going to take them ages to do, and often I've sent people out to go and make a cup of tea, and I said, what I really need you to do is go out and make a cup of tea, because then that they're going to be gone for at least 5 minutes whilst the kettle's boiling and everything else, and they'll come back, and a lot of the time they'll think that's a really important thing to do, and that they need to do it to help you manage their child properly, and it removes them from the situation and gives them an opportunity to go and calm down. Another thing to do is to ask them to go and find child's favorite toys or something that will console them, and come up with a long list of things that you think might help the child, but also take some time for them to find. So they're really important things. If you do get if you do suspect a non-accidental injury, then and you do manage to get them to leave the area, then use that opportunity to get some more information from the child really quickly, if you can, if they're old enough to be able to communicate that with you, and explain to them that you're just there to look after them and to help them, and by giving this information, it will help you do a good job looking after them. So that's when you might not want the parents to be present. There's another slide coming up.
James, I think Dawn's back now as well.
Oh, shall I shut up then and let Dawn carry on?
He isn't.
I'll carry on then.
Sorry.
No, that's all good. That's all good. She'll hopefully, if she can hear, she'll interrupt me anyway and tell me that she's on. So that will get her off. I'll send her a message. So safeguarding is obviously we spoke about that being an important thing, and it's part of your training that you do every year. But it's not just non-accidental injury. So there's some social factors. So if you enter a scene and you notice that the clutter rating of the house is really high, it's really dirty, there's no chance that the kid's being looked after in a safe or hygienic fashion, and that's putting them at risk of neglect. That's a safeguarding cue for you as well. Unfortunately, we do live in an age where exploitation of children for work or other things that make people money, so including sexual abuse, and filming that and distributing it is a thing. So if you notice any of these things, it's a cue for you to make a safeguarding referral, and that's what I mean by the dark stuff. There's some really not nice people out there, and unfortunately, in our roles, they're the people that we are more likely to run into in these sorts of situations with children with major injuries or other major problems. So just to be aware of those things and always have it on your radar. And the important thing is, even is to hand it over to the hospital when you arrive there, that you have some safeguarding concerns, but don't rely on them to make the safeguarding referral, although I'm sure they will do. We all have a responsibility to highlight this, and all NHS ambulance trusts have a mechanism for doing this, and it is really, really important that you do that, because it's the only way that that child can be given some help, and protected from exploitation, neglect, or abuse of any kind. I don't know what's next, Eric. There we go. So yeah, communication and pre-alerts are a really important thing to do. Your standard at-mist format is what you're used to doing for pre-alerting departments for trauma cases, and it's no different in children. Is just use your normal format that you're used to doing and used to communicating slickly, to get the message across. If you are suspicious of any safeguarding concerns, including non-accidental injuries, it's a really good idea to communicate that during your pre-alert. Now that can be challenging, especially if you've got a parent in the back of the ambulance with you. You don't really want to be saying, yeah, I'm suspecting non-accidental injury or parental abuse, because they're going to hear that, and that's going to change the dynamic in the back of the ambulance. So most parents won't know what an NAI is, or SPA, and they're good little acronyms that you can use to communicate that. And you will 100% get asked for more information by whoever's picked up the red phone in ED. But I usually just style it out and say, everything's fine, and dad's in the back with me, and they get the hint, and stop asking questions. But it means that they can get the right people to the department, and they can plan for moving the parent away from the child so that they can get more information and examine the child in an appropriate way, to be able to find more information that would substantiate any claims of non-accidental injury or abuse or safeguarding concerns as well. And as we just said, safeguarding referrals are really important, everyone's responsibility. And if there's 20 safeguarding referrals made for the same child in the same incident, that's a good thing. And we shouldn't be relinquishing our responsibility to do that to other people because we've handed it over. Obviously, we're all in our jobs to do good things for people, and it's that most of the safeguarding referrals are really, really quick, and we should all just do them.
Can I just add to that?
Yes, take over.
Sorry. Yeah, I'm back again. No idea what's going on with my internet. So with regards to the safeguarding, so we should certainly be adding those in, because we are quite privileged at the fact that we see the home in its raw state. They've not had time to tidy it up and so on and so forth, generally. So we can get those clues from within the home as well. So, and that should go into your report as to anything that you may have noted, including who is there. So yeah, definitely don't think, oh, I've handed over now, they'll do the referral. We do want to. Thank you. Right, next. Okay, so moving this child. So safety first. So obviously we're having to strap them in, whether that's on the stretcher or not. Obviously, use the harnesses. So I know not many people like the Pedimate. I mean, I quite like it, but I used to work within the training department of the trust, and so I was quite confident with it. But certainly the Pedimates are very useful, and obviously you can strap the child to the stretcher as well. And we mentioned about head injuries, so such as like maybe putting a cupola blankets underneath the scoop stretcher if you've got a scoop, just to keep the head a little bit above the feet so that we can help with that drainage, so with regards to the head injury. And then obviously driving with care. Now the biggest one here is probably what you really want to do is just put your foot down and get out of there. And obviously we think about, it used to be scoop and run. I like to think stay and stabilize, and then obviously get the patient to where they need to go. With that, what we need to be really considerate of, especially with head injuries, because the majority of pediatric trauma is generally head injuries. Obviously, they do have other injuries as well, but such as harsh acceleration and braking is not good for the patient. And that's not just pediatrics, that's in general. But certainly harsh acceleration and braking is not good, and with the cadence as well. So we can still make haste and make way by doing the speed limit or a sensible speed. So don't feel you need to put your foot down doing 100 miles an hour to get us there. You can still make a good speed at a reasonable speed. A destination that is appropriate. So thinking, obviously we want to take to possibly a major trauma centre. Obviously, as was mentioned, there's, if you're not sure where they are, there's a lovely infographic on KidConfident which will highlight where they all are, or if, especially if you're out of area. But certainly you probably know where your paediatric major trauma centres are. So just having to think where they are and taking them there, using the trauma tools to help you with that decision making. Otherwise, if you've got a very unstable patient, as we would in the adult world as well, because again, children are just small adults, so with regards to major trauma, then take them to the nearest appropriate ED so that they can be stabilized on for secondary transfer. And that's where that bottom one comes into it as well. So a lot of pediatric patients will probably turn up via parents or carers to ED who don't know the difference between a major trauma centre or a trauma unit. Okay, so actually they've gone to a hospital, taken their child in, and so those secondary transfers might be required. So it's not that failure of pre-hospital care at all. And like I say, it could well be that they've had to go to that hospital to get the patient stabilised, or the facilities within the major trauma centre, such as neuro, surgical, etc., may not be readily available. So I'm thinking more probably your burns units. So if you've got a patient quite significant burns, you've taken them to the major trauma centre, they might need a secondary transfer then to a burns unit. So again, it's not a failure of us within the pre-hospital care. Do not worry. Okay, and then let's wrap this up. I think that is where we are. Yeah. Okay. So in summary then, so we've gone through those technical and non-technical sides of paediatric trauma. There are some small differences between adults and peds, but essentially we do the same things to both. It's just adjust your size of equipment and your drug dosages, etc. But it's still that C, A, B, C, D, E treatment. Okay, scale it to size. Oxygen, all trauma patients generally get oxygen anyway, don't they? Check their glucose, make sure they've got a good temperature, so want them normothermic, and a little bit of extra attention. And don't forget safeguarding. It should generally be on your radar, just whether the stories match up and whether the injuries match the story. Okay, I think that is it.
I lost my Zoom button, then it completely disappeared. Hello, Jean, good to see you. Right, so where is, oh, she's done it again, where she's not closed the slideshow. Right, let me just get the keynotes up. So before we continue, as per usual, I just want to draw attention to our next webinar, which will be taking place Where are you all? There you are. Sorry, all. Which will be taking place on April the 17th. We are going into extreme medicine for the first time in a while, actually. So we've got Dr. Sarah Hollis joining us talking about freezing cold injury and non-freezing cold injury. So it's going to be a fascinating webinar. So do scan the QR code that's on your screen now, and hopefully we'll see you in 2 weeks' time. Moving on to everyone's favourite part, Q&As. So if you're not a trauma care member, this is your chance also to get your CPD certificate. So if you scan the QR code that's on your screen now, it'll take you through to a type form. Don't worry, it's nothing else to sign up for. It's just a form that you fill out. And by filling that out, pay £1.99, you'll get your CPD certificate sent straight to your inbox as soon as you click submit. If you are a trauma care member, hang fire, don't scan anything, don't do anything. You'll be receiving your certificate first thing tomorrow morning. So on to the questions. So the first question came in at about 20 minutes ago, and it's from a Jimmy Ronaldson. So they've asked, what's your experience of using Penthrox for kids and using Oromorph in pre-hospital environment?
Yeah, so do you mind, Derek?
Go for it.
So we don't, certainly where I work, we don't have Penthrox readily available, but we do have Oromorph, and certainly I have used it within pre-hospital environment for children when obviously vascular access is quite difficult, and I certainly wouldn't want to try and go for IO in these very awake patients. So Oromorph certainly works, but don't be afraid to use the power of Calpol. Absolutely. So kids know what Calpol does because they've probably been fed it for most of their lives and realize it does make them feel a bit better. So don't be afraid to start off with Calpol if able to as well. And I'll hand over to Derek.
Yeah, so it's a great question. I really want to use Penthrox even in the D department. So there's a paper, research trial that's due to be published this year called Magpie, which will open this up for in paediatrics. Some areas, so Elderhay and a couple of others have taken Penthrox and using it certainly in the acute setting. It's super useful. I think it will be an adjunct that we can add, but I wouldn't. Again, it's sort of trying to think of that as an additional tool rather than something that is just required as a single agent. But yeah, I think that will be a game changer hopefully for us. I don't know if anybody is using Penthrox pre-hospitally in paediatric group of people, but I'm not aware of it if it is.
No, I'll just add to that, like the licensing for Penthrox at the moment is only for adults. But in Australia, they do use it in children and with good effect as well. But at the moment, it would be an off-label use. So it's probably not going to be something that you'd reach for at the moment. And as Derek was saying, the Magpie study is going to hopefully inform a change to the licensing in the future.
Wonderful. Thank you very much. So I have managed to catch this one. So luckily I have managed to catch a question in the actual chat. And someone has asked, is there a role for collars for suspected neck injuries?
Never.
No.
I knew you'd like that one.
Yeah. So it's
Wonderful.
it's not something that's used at all now.
No.
So like
No.
the exit trial will say that it's you get some less C-spine movement if you put a collar on to extricate someone from a vehicle to assist their extrication. You might get less movement, and that was done in adults, but generally we wouldn't use collars in children or adults for immobilization. But using your head blocks and tape is still an acceptable thing if they'll tolerate it, as Derek said earlier. So if they're thrashing around their prop and you're tying them down to a scoop with blocks and tape, there's a risk of causing more damage. So yeah.
And looking at some studies from a couple of years ago, there's actually only about 2% of paediatric trauma that has a cervical spine injury. That doesn't say don't think about it, but certainly it is quite a low instance.
Wonderful. Thank you. And an anonymous attendee, every single question that's left is an anonymous attendee now, so I'm just going to roll through the questions. Has asked, what is long bones to length?
Oh, so shall I answer that? Because that's my stupid phrase. So if you've got someone who's got a long bone fracture and it's not straight, then it's just literally it's just pulling it to length. So you're trying to get the two ends of the broken bone together. So as you would do in an adult, you might use a traction device if it's a female or something, or if they've got a bendy arm that's bending not at the elbow, then just putting some traction on it to splint it into an anatomical position, and that will reduce bleeding from the inside of the bone, help your hemostasis, and it will also provide some pain relief as well. So it's a really important intervention in part of your hot approach in trauma for all ages in adults and children. Hope that helps.
Wonderful. So anonymous, I'm not going to say the name because they're all anonymous. There's been a move away from using mum and dad as some parents dislike it. Do you find this isn't applicable in trauma?
Can I
Yeah.
answer that? So it's interesting. I think it's a really valid question, to be fair. I think people respond better to names. But that's requires a lot of bandwidth to be able to remember somebody's name in a trauma situation. So you always get people's attention if you call them by their first name. But I use mum and dad all the time, and I think that's appropriate. And I think it does have we were talking about trying to bring people back down to what their responsibilities are. And saying mum and dad is something that's completely appropriate, I would argue.
It's also there's some studies about post-traumatic stress in parents whose children have been critically unwell or seriously injured, and you're kind of involving them might be difficult for them at the time, but it's really important for the child because they're the usual source of comfort, and it also then removes any risk of guilt and reduces the instance of post-traumatic stress for the parents in the future, because they know that they've been involved and they've done the best thing for their kid, and so I think that's a really valuable thing as well. Although it's not like directly applicable to the immediate priorities, it's something that will shape the relationship and everything else with the child in the future. So I think it is still important, and there is some evidence to suggest that it is still a good thing, although it is difficult at the time. Obviously, if they're really emotional and interfering with your ability to deliver care, then it's not helpful. So then that's when you might want to remove them or keep them in the front of the ambulance rather than in the back. But generally speaking, I found it is useful to have them immediately available if it's practical.
Wonderful. And James, just whilst we have you, someone's asked, do you know when the pre-hospital CID cards will be back in stock?
He's the guy who does them is working on a new version, and he's updating a few bits and making them look a bit more jazzy. So when he's finished doing that, they'll be back out. If you join the KidConfident Facebook group, we do have some copies that we give away free for engaging in activities and discussions on the group. So feel free to do that, or you can send us an email to contact@kidconfident.org or through the contact link on the bottom of the pages on the website, and we might be able to get you a set.
Wonderful. Thank you. So someone's asked, I'm a first aider and would just like to ask, given what you've said about glucose, if we're waiting a substantial amount of time for an ambulance, should this also be something that they think about?
Yeah, if it's in your scope of practice, if you have the equipment and it's something that you're trained to do, then taking a glucose, peripheral glucose, capillary glucose is a good thing to do. Obviously, you won't be replacing with intravenous glucose, but if they're conscious and they've got a safe airway, then giving them the normal treatments as you would for a diabetic. So sugary stuff basically is absolutely a good thing to do if their BM's below 3, definitely. I usually do something if it's below 4 because I don't usually have the bandwidth to think of the different blood sugar levels and the different evidences that seems to change every week. So I would advocate doing that. Haribo and their favorite sweets are usually a good thing to do if they're conscious and able to take it.
I just also add to that you can really manage glucose well by keeping kids warm. So one thing that happens when kids get cold is that their sugar drops as well. So particularly in babies. So warmth and sugar go together. So even if you can't do something particularly about keeping them warm, if you can't check the blood sugar, keeping them warm will address that as well.
Brilliant. So, and actually, so someone say it's kind of a follow-on, so it's going to be a very quick answer this, but I don't think it was fully touched upon when we were just talking about blood sugars. Should you be checking blood sugars multiple times in trauma? Should checking blood sugars multiple times in trauma be high on the priority list, especially if we're only with them for 40 minutes at the most? Could there be a significant drop in a short amount of time?
So I've seen multiple boluses given pre-hospitally before, with the sugar that goes up and goes down again. The more sick the kids are, the more likely that is to happen. But actually, it's about priorities and what's important. I think I would ask people to try and check the sugar and address that. But I think if there's other stuff going on, then it's completely fine to say, like, I've addressed this. It was though I've given it something, and in your handover you'll be saying you've corrected some sugar. And one of the first jobs we always do is look at sugar. So yes and no. It depends. If you've got time to do that, then I think it's completely appropriate to check it again, and you may find that it drops again. But I don't know if you have anything to Don or James to add to that.
I mean, yeah, I would say that, and we'll talk about it more in the head injury one in June. But it's definitely something to keep an eye on. If you've got A, B, or C problem that you need to manage, that's a priority. And if you've got a really badly injured child or a sick child with a normal glucose, I personally like to check it again about 30 or 60, at least 60 minutes later. But if I've got capacity, then I'll try and do it 30 minutes later to see that it's not dropping. And if I've done 2 that are stable-ish, then I'll stop checking it and stop thinking about it so much, unless something changes, like their level of consciousness. But yeah, I think it is important, and especially if you've got an unconscious head injured patient and your initial blood sugar is normal, then I would check it again between 30 and 60 minutes later.
Brilliant. And I can see that Dawn is typing an answer to this one that's going on, and it's gone. So that is, with it being 9:15, that is all the time, all we have time for this evening. So thank you very much, everyone, for being with us tonight. It's incredible to see such good numbers joining us for a trauma care webinar. And thank you for 3 presenters joining us this evening as well, which is it's so wonderful to have that. And to have KidConfident back with us, as always, is a pleasure and never a chore, unless James is buying you extra pints in the bar at a conference. However, before we do say goodnight properly, I just want to give a huge thank you to our trauma care sponsors. Without these guys, we wouldn't be able to carry on doing what we do, as well as our members. It's these 2 combined that bring us all together and allow the conferences, allow these webinars, and allow everything to happen. And especially for the guys like QualSafe, who also help us pull together our first aid stream every single year without a fuss. So a huge shout out to QualSafe. If you go to qualsafe.org, you can find out more about them. They've got, and I know that we've got a few CFRs and first aiders in the audience tonight. So this is a perfect site for you guys, because they have loads of FREC courses. They've got first aid courses that you can do in your own time, or you can go on site to cover. So do check them out by scanning the QR code and finding out more about them. And of course, our brand new sponsors, the wonderful TCAR, Trauma Care After Resuscitation, and PCAR, Paediatric Care After Resuscitation. If you go to tcarprograms-uk.org, you'll be sent to their UK website. They've got some brilliant courses coming up all across the UK in Leeds, Glasgow, and Liverpool. If you click on, I think it's, I can't remember which resources, there's a tab on there that's the second to the last tab, and you can find out more about the courses that they've got coming up. And they're cheap, they're there, they're happening very, very soon at the end of June. So do scan the QR code that's on your screen now, go to the UK website and find out more about what they have coming up within the coming months. And of course, finally, last but certainly not least, our wonderful friends over at Galen. Hopefully some of you saw them at the conference. If not, I say it every week, but I'm not allowed to say too much about them because I'm not qualified, but they are a pharmaceutical company, hence not being allowed to say much about them. But do scan the QR code that's on your screen now, click on the For Medical Health Professionals on there, and you can find out all about the different products they have available, some that you probably want to read up on because they've got some stuff being released soon, not saying much, that you will probably end up using in practice at some point. So do scan the QR code, find out more about them, and yeah, apart from that, all that we have left to thank are you guys. And I can see there's still a few of you in there from all around the world. Again, it's so brilliant that we get this worldwide audience joining us. Thank you very much. From wherever you are in the world, take care of yourselves, take care of your loved one. Dawn, Derek and James, thank you very much for being with us this evening. Have a good evening wherever you are, and good night.